speaker would be Dr. Subhashini KADAPPU, and from Australia, and her topic would be tips for glasses prescription in children with strabismus. Okay, Dr. KADAPPU, please.
So the podiums are typically alternate, so the next speaker will be speaking from there. Good morning, everyone. It's a pleasure and a privilege to be here. I thank Sunil and the APO committee for making me a part of this session. So we're going to delve into the very basics of pediatric ophthalmology here, which is prescribing glasses in children and specifically in children with ocular misalignment. We all know that vision testing in children is no easy feat. Children often are very difficult to examine, and the examiner often needs to be very patient, needs to reserve a lot of time, and also need to have quite a bit of experience in measuring vision in children. The vision measurement not only depends on the age, also on child's attention and ability. A very young infant, a child very uncooperative, or a child with developmental disability, you might have to modify your vision testing accordingly. And sometimes all you may get is a fix and follow or a central steady maintained fixation, or even just equal objection to cover. So hence, in children, we still have cycloplegic refraction being the cornerstone of refraction. This is a very age-old technique and it still holds good till today. In Sydney, western part of Sydney where I practice, we are quite multicultural. So the choice of drops depends on predominantly on the color of eyes, and also the percentage of drops depends on the child's weight. If it's less than 10 kilos, you're using lesser concentration of cyclopentolate. So the part with the worst bit of pediatric ophthalmology is the children and the parents hate coming into the clinic. And it's very important for you to inform the parent about the process of the eye drops. And we need to involve them, because otherwise it becomes quite overwhelming for a parent as well. So the drops often needs to be repeated in a dark-eyed child. Incomplete cycloplegia or ocular misalignment often can cause that is probably our everyday practice in pediatrics. So incomplete cycloplegia and ocular misalignment can cause very erroneous readings on refraction. So often the refraction may be over or underestimated if the pupils are not fully dilated, or if the eye is misaligned because you're not in line with your retinoscopy beam is not in line with the pupils. Sometimes we may resort to atropine, especially if you're suspecting accommodative esotropia with high hyperopia. Very occasionally, we resort to examination of the child under anesthetic, and I try to find an opportunity of another general anesthetic procedure to combine my refraction with. So retinoscopy still is the main tool in the age of AI and automation. We are still not going anywhere without the retinoscope. So once we have had a refraction, you've taken off the working distance, there are many factors to consider before we actually decide to prescribe. And most importantly, the age and the ocular alignment. Symptoms are very minimal in most children with refractive errors when they're very young. So if I put this busy slide, the audience is going to be disinterested, and so will be my registrar in the clinic when I'm trying to tell him what are the guidelines to prescribe. So I usually tell them a very simple rule of thumb. This may vary among clinicians with various expertise in different parts of the world, but this is what I tell them simply. Any hyperopia of more than 4 diopters is worth prescribing. Again, it might vary depending on the child's age. We usually fully correct astigmatism and anisometropia. The only easy thing here is you have to fully correct hypermetropia associated with esotropia. Once I've prescribed the glasses, I again spend another 5-10 minutes with the child and the parent and explaining what type of glasses they need to get. They have multiple questions. They're overwhelmed with the diagnosis of a refractive error. So you need to sit with them and explain that glasses need to be worn full time, needs to be fitting the child well. The lenses need to be shaved thin if they're high refractive errors, and the vision improvement is not immediate. So the child's going to wear glasses and is going to complain of blurry vision, and it doesn't mean that you've given them wrong glasses. And often you do get calls from the parents about this, or the optometrist telling them that that may not be the correct prescription. So I do spend extra time with the child. Now, we know about the eye growing quickly, achieving emmetropia around 6 to 8 years of age, but we know the children are still hyperopic about 6 to 8 years of age, and we often see overprescription of low plus glasses. And this is not usually recommended, but the children are usually presenting with vague symptoms of near blur, headaches, and even learning difficulty get prescribed low prescription glasses, while actually it's not a visual difficulty, it's a learning difficulty that needs to be addressed. The only hyperopia that I prescribe is more than 4 diopters, and I usually undercorrect by a diopter and a half. I usually associate astigmatism and anisometropia is fully corrected. You need to advise the parents that it's going to be a slow progress with vision, and it might take months to years for the vision to improve. The hyperopia slowly diminishes in the late primary school, and they usually tend to prefer less prescription as they get older. Bifocals is very rarely prescribed. I do probably if they're hypoaccommodating, and especially children with trisomy 21. So coming to esotropia associated with hyperopia, we usually fully correct hyperopia of anything over 1.5 diopters. Now, we need to be mindful because there are some accommodated esotropia that can present acutely, and if they're still significantly hyperopic, I treat them as acute accommodated esotropia. But if the hyperopia is not very high, then I have to think about other causes. Need to look for full abduction to see whether the child's well, and may even require imaging in some cases. It's a non-accommodative esotropia. Now, I bring the child back in 3 months just to see how they're wearing the glasses, whether the glasses have been made correctly, and if they're still significantly distant esotropia, and if I'm concerned about undercycloplegia, I would probably do a repeat atrophy and refraction and correct any residual hyperopia if there is. If not, then I'm looking at what how their vision's going, and if they're micro ET, I'm still monitoring for amblyopia. If they're partially accommodative, again, amblyopia is a factor that we need to monitor, and I do an annual refraction, and then probably office surgery if the esotropia is still significant with the glasses. There's one subset where the esotropia is significant for near, and then I stick on +3 over the current glasses, see whether I improve for near, and I prescribe the bifocals with the near out of +3. It's important to give the advice on your prescription how the near segment needs to be. It needs to be quite a large near segment with the top of the D segment bisecting the pupil. So the natural history for accommodated esotropia, you find that once you refract them again next year, you find that the plus has increased. And this is a natural progression, and you need to advise the parents that it is actually going to increase before it improves. And this discussion is important, otherwise the parents think the whole idea of giving glasses is to make things better, but it's actually gotten worse. You also need to advise that once they start wearing glasses, the esotropia without glasses may be worse, and this is because of less accommodation. So infantile esotropia is also I needed to discuss because I usually give them +2.5 if their hyperopia is higher. I tried glasses before surgery. Intermittent exotropia will still fully correct myopia. I would fully correct associated astigmatism. I don't prescribe any prisms or low plus glasses, and I undercorrect the hyperopia. Usually they do improve. Over minors, I do them in specific cases. They have a good control for near, and they do maintain their exotropia with their glasses as long as they're wearing them. There is no usual concern about myopic shift. Usually these children are myopic anyway. So I'll leave you these tips on how to manage refractive errors in children. Thank you for your time.
If there's any question, okay. Thank